Thank you all for being here. Welcome to the Managing Healthcare Data, Exploring the Opportunities and Challenges conference session. My name is Robert Rowley. I'll be moderating the panel. We have two very distinguished members of our panel here. Just to introduce them, David Stein at the far end there. He's regional administrator for CMS in the San Francisco office, which covers California, Arizona, Nevada, Hawaii, and Pacific Territories. David and his immediate staff will focus on external and intergovernmental affairs. The San Francisco regional office is pretty huge and one of the most culturally diverse populations in the nation. Serves more than 14 million Medicare members, Medicaid, and Children's Health Insurance Program beneficiaries. Seated in the middle is Dr. Pierre Theodore. Earned his medical degree at the University of Virginia School of Medicine. Completed a residency in general surgery and cardiothoracic fellowship at Johns Hopkins. Joined UC San Francisco Medical Center in 2004. Named as the first recipient of the Van Auken Endowed Chair in Thoracic Oncology in 2007. Served as Lieutenant Commander of the U.S. Naval Reserve Medical Corps, Assistant Professor of Surgery at UCSF. And then myself, Robert Rowley, I'm a practicing family physician, healthcare information technology consultant. I had been the original creator of and chief medical officer of an EHR company, Practice Fusion. Left that company in 2012. I've been working with another startup. Used to be called Group MD, is now called Float Health. It's a next generation communication platform for care teams and patients, facilitating transitions of care and aggregating patient-centered data from all the sources where it's found. So that's a little bit about us up here. I wanted to maybe frame the issue of managing healthcare data because that's a fairly broad paintbrush of possible discussion. And talk a little bit about some of the challenges and a little bit about some of the opportunities, and then ask the panelists for their insights on these challenges and opportunities and ask some specific questions. And the way I look at it, the challenges right now with healthcare data is that it is compartmentalized within institutional silos. The institutions can be really big, but it's still, data doesn't cross the walls very well from one institution to another. And that is a challenge. There's a challenge of getting the data, interoperating the data, connecting those silos together. There's inconsistent implementation. Even one giant Epic install to another giant Epic install has trouble talking to each other. But people are trying very hard to get those pipelines connected. The aggregated patient-centered data is still an immature market, though it's starting to grow. We might have a very different kind of discussion a year or two from now as that starts to become more commonplace, and we start to see that happen. On the other side, the opportunities, analytics can be done even within large silos. Very large data sets, there's CMS data, there's Kaiser data, there's payer data, and some very useful insights can come from them. There's insights into clinical care that have resulted from data even across the different silos. And also, as we start to change how we pay for healthcare from more volume-based fee-for-service to value-based compensation, that relies on population health metrics, and both clinical quality metrics as well as individual patient clinical decision support. So that's kind of how I see the challenges and opportunities. And before asking specific questions, perhaps we could ask the panelists to chime in on, give us their perspective on these questions.
Hi, everybody. It's a real pleasure to be here. We have really turned a page of history this week in terms of closing that first open enrollment season. Over 7 million people in marketplace plans, another 3 or 4, or maybe much more, I don't know, in Medicaid plans. And even if not that large a proportion of those people were uncovered before, the thing that's really different, the historic thing, in my view, is the sort of civil rights angle of the law, which says that no longer do we discriminate against people because of their health status. I think that was one of the biggest barriers around healthcare privacy, and what has a lot of people really nervous about it, is because I had a friend over last night, and she's concerned because she wants to have this expanded life insurance, and they want to be samples from her, and they won't tell her what they're actually going to do with them. And I thought, well, that's interesting. I thought if somebody wanted your blood or whatever, they should have to tell you what they're going to test for, but evidently they don't for life insurance. But they can no longer do that for health insurance. And so freeing people who are locked in their jobs, freeing people from the concern of can I get insurance because I had breast cancer, because my kid has this problem. Really huge thing, and I think that's going to make it a lot simpler to solve this conundrum around individual person data and data that's owned or housed by providers or insuring organizations. We did a pilot in the Bush administration on a Medicare PHR project in Arizona. It was built around the blue button idea. We had 4 companies. One of them was Google, one of them was Microsoft, one was known as Clipboard, I can't remember the other right now. The Medicare beneficiaries, the theory was we would populate, if they chose one of these 4 products, we would populate with their Medicare claims history, and then they could take it from there, but it wouldn't continue to populate with Medicare. The companies would do that. And the companies had strategies to get pharmacy data and so forth. The beneficiaries hated it. Nobody liked this idea, even though these are Medicare beneficiaries. They maybe don't realize that the government always has this information about them anyway. But people were just scared of the idea of, oh, my data on the internet and be hacked and all that. So that's the thing that we have to overcome. There's kind of an unrealistic fear that people have in this age of the NSA and so forth. But the world that I see, I think the beginning will be when there are good personal health products for people like us, and people companies try to do this and failed initially, that would allow us to own the data and allow us to pull data from our providers. And I think nuclear stage 3 will probably be requiring that kind of structured data capability. You could see people then beginning to build this architecture, and that's the only commercial way I can see it done. Because I'll close with a quote that David Blumenthal made at a conference that I love a few years ago, which was that there's no natural market for healthcare data exchange. And there isn't. So we've invested a lot of money as a government in creating that. A friend here from California today has been working on that, one of those grants. And the question is, do we light enough of a fire there that it'll continue to burn by itself? And that's something we'll probably touch on today.
Thank you, David. That's a wonderful introduction. I actually love the fact that we have this kind of lean team that we're up here. And in a sense, David really representing, if you will, kind of the federal government's approach to paying for healthcare. And then from my perspective, as a clinician, really think about how we can apply the aggregation and, if you will, the distillation of big data sets in actual clinical practice. And I think what I'd like to sort of drive home is the fact that traditionally, perhaps the last 45, 50 years, the gold standard for, say, for example, developing a trial that says that one particular therapeutic modality is superior to another is a randomized, prospective, blinded trial. And that's fantastic. It's come to be, in fact, when I was in medical school, I was told by the professors that you shouldn't even read a paper that is not a randomized, prospective trial. But the fact is that it has become extraordinarily expensive to run such trials. And in fact, when we have a ballooning number of therapeutics, a ballooning number of therapeutic modalities and treatment strategies, it becomes impossible to try to continually develop these de novo trials. So at some level, we have to sort of take, if you will, a quote, retrospective look at the data in order to help govern our care. And I often say, my 4-year-old, I tell the person, the 4-year-old, not to put her hand in the fire. It's because of retrospective data that I have to know that putting her hand in the fire is not a good idea. And I think the same thing is probably valid. Some of the most important modalities that we have, for example, in cardiothoracic surgery, use of bypasses, stents, and the like, largely that data comes from retrospective analysis. And the question is how to make that retrospection truly valuable, that's truly influential, that actually holds weight to payers, insurers, to the government, and the like. And that's what I'd like to kind of spend a bit of my time emphasizing today, is really how the distillation of that data can help govern clinical practice. And we'll talk about a few examples of that.
Thank you. A few questions that I've kind of jotted down here, and then later on we can open up for questions from the floor. But first is the question of how does leveraging healthcare data support value-based payments and value-based purchasing? And start with data. What is CMS doing with this?
Well, there's an expression that we use frequently, which is good government. So there are ideas that do not have a partisan basis. And this notion of value-based purchasing really goes back to the 90s, the Clinton administration. Bruce Vladeck was our administrator. He's the guy that had stood up the prospective payment system in New Jersey back in the 1980s, which itself is a pretty interesting data play to think about it. But bringing that forward in the Medicare Modernization Act, so the Bush administration in 2004, we did a number of demonstration projects around disease management. They didn't pan out very well, but we did an important thing, which was that we created voluntary quality data reporting for hospitals. And Tom Scully, who was the administrator at the time, said, you know what we're going to do? If you want to get your update next year, you have to submit the data. And right away, almost all the hospitals began to submit the data. And in a couple of demos we did there, the hospitals really were able to improve things. So move forward now the Affordable Care Act, again, much of which comes out of a largely Republican thinking in Senate Finance. You get accountable care, you get bundled payment projects. None of these things would be possible without the information that we have. So we started our program in 1965 with a 1940 fee-for-service indemnity insurance model based on reasonable charges and the cost of the hospital. And now what we want to do is, rather than buy individual services, buy that value. And now it's in sight to do that. So hospitals' reimbursement now is increasingly dependent upon these things. So a portion of it is dependent upon the patient's view of the provider, the patients, the caregivers, and so forth. We do surveys. So if you read surveys about this hospital is better than that one, the only ones that you can compare across the country are ours. And U.S. News and these other people are just using the government's data to make money, which is a really good idea, and I encourage all of you to do that. That's what we want you to do. And so this fall, we're going to begin doing that on the physician side. In fact, we announced yesterday, based on a decision that happened in Florida, we're going to begin very shortly releasing volume and claim information about the 880-some eligible professionals that we work with. Something like $12 billion in spend in just 2012 claims. And that's going to be a lot of information that may be useful. You won't be able to identify patients, but you will be able to identify those practitioners, and there could be a lot of interesting work done around that. So this whole notion of paying for value, you have to have a way to measure the value, and you need a lot of data points, and it becomes very big very rapidly.
I think just to sort of dovetail with that from the clinical perspective is that, and it's actually a tremendous responsibility that CMS and David has, which is that the things that they choose to pay for are the things that we will often do as clinicians. And that those guidelines are really based on the data accumulation become extraordinarily influential to what a physician will do in common practice. And so in conferences, for example, when we discuss DVT prophylaxis when a patient enters or exits from surgery, or when we talk about a patient in the emergency room and whether that patient should get antibiotic within the first hour or 2 hours, those kinds of practices, those kinds of protocol-driven activities, which we think ultimately lead to better outcomes, largely derive, so there's, if you will, there's kind of a two-way influence here. The data is being accumulated day by the practitioners to sort of, essentially to show best practices, which are in turn then being interpreted by the government as determinants of care. They say this is the way that the care should be delivered. And that in turn feeds back to the clinician, so that the aggregation of data ultimately ends up, we would hope, lending to better outcomes, of course, which is our ultimate objective. I give just one very brief example. There's a procedure called a lung volume reduction surgery. If any of you smoke, you ought to stop. But if you do, then there is some hope for you, which is an operation where we essentially take off the top of the lung with a large stapler. We do this maybe a few times a month. And there was a period where there was an explosion in these operations throughout the country. Some people had estimated it was going to be one of the more common operations done in the early 2000s. But soon, very quickly, it was noted that the outcomes were fairly poor. The data was mined, it was evaluated through several randomized prospective trials. CMS interpreted that data and said, you know, we're actually only going to pay for specific small numbers of those types of procedures. Very specific criteria. And then what you see is the number of those procedures within 6 months to a year dropping off to negligible. You know, literally in some cases 50 to 100 being done nationally per year. So that's kind of an example of that sort of feedback loop between the clinicians acquiring the data, CMS determining what they will pay for, and then in turn for the physician practicing in their day-to-day activities.
Terrific. You know, this conference happens to be in a real hotbed of innovation. This is a very nurturing environment to people with new ideas, startup ideas. There's a whole VC model of incubating and encouraging entrepreneurs to start up companies which, you look around and there's companies that have changed the world as a result of this kind of environment. So with that backdrop, so why is innovation such a high priority for CMS? Start with David.
Yeah, it's interesting. I was here earlier, and the moderator of a panel pointed out that you should really take a look at the exhibits downstairs, because it shows you that we stand on the shoulders of these people that did this amazing work. So I took a little time to do that. And that's the sort of the story of computing is familiar to me. I was a computer guy when I was younger. But the sense you get of that building, it makes me realize something I think all the time, which is this. Lots of times when we go out and talk to people and they kind of get into the conversation, healthcare, why can't we solve this problem? People will say, well, we just need to do what they need to do in Taiwan or France or Germany, to solve this problem. And my retort is always, well, we're not any of those places. We don't have the homogeneity of population. We're not basically socialist country. We have different ideas. Our problems are not their problems. And what we've always done is innovated our way out of our problems, and I think that that's what we'll do here. The thing that's the challenge is in medical costs, which are moderating, but they're still continuing to grow somewhat. The growth comes from the innovation and the new stuff. So it doesn't come from people getting older. It doesn't really come from that much volume and intensity or fraud. It comes from new stuff because by law, when we consider in Medicare to cover a new procedure or product, all we have to look at is it safe and effective and approved by the FDA to do that. It can cost 3 times as much and not be as good as the existing therapy, but it gets approved. So that's what we miss. We lack that quantitative effectiveness, that comparative effectiveness work that we need to bite the bullet and do. Because when we do that, I think there's a push-pull between regulation and innovation. If there was no regulation, there wouldn't be a roadmap. So you have the problem that we have with the patents now with Apple and Samsung and so forth. You got to have a good grid to play the game on. We're trying to create that grid, and when the grid squeezes, the real innovators figure out a way around the squeeze. And I think that that's what you're going to see happen. I think we're going to move into more of a comparative effectiveness space, more transparency, so people can look at things that are effective. I had a surgery done, and it was most unpleasant. It took a long time to recover. It didn't solve the problem. When I went back and reviewed it, I discovered it only had a 65% chance of working. And no one ever told me that. And that's the kind of thing I think consumers need to know, and that's what we're going to see that's going to drive the transformation.
Yeah, just to make a brief comment, and Robert, you may want to comment from your perspective and some of the startups you've been involved in, is that we often talk about trying to sort of break down silos, and we're here to sort of connect data from one group to another. But sometimes it's valuable to ask, well, why do the silos exist in the first place? Why is it such a big struggle for that data to transfer? And part of the reason why is that traditionally we are competitive. I'm at UCSF. There's another hospital in town. There's a hospital down in the peninsula at Stanford, and we are competitors at Stanford. We would much prefer that if you're ill, I would much prefer that you come to see me than my counterpart at Stanford. And that may sound inappropriate, but that is the truth, and that's how clinicians often see the world. Whereas by contrast, my teenage son, he's not competitive with his friends on Facebook. He works collaboratively with that group. But the point I'd like to make is that there is a bit of a sea change going on in the medical world right now, where we are being encouraged or forced to actually come together into sort of these collaborative networks. And whether it's something like accountable care organizations or medical homes and the like, where you start to organize loosely aligned groups, but also the payers say, look, we're not just going to pay for every single procedure that you do, but you're going to have a certain allotment, a certain payment for this patient for maintaining health over time. So there's a bit more of a, if you will, a social connectivity among caregivers. It's difficult to precisely put a finger on how that's happening, but what I would anticipate is that that spirit will lead to a little bit more of these silos dropping, a bit more sharing to lower the overall cost and keep our revenues up.
Just to flesh in from the perspective of a physician entrepreneur, I look at the data silos that exist now, the institutionally centered data silos, as being the result of the evolution of the EHR industry. Before there were electronic health records, doctors kept their paper charts in their chart racks in their offices. It was basically paper-based databases that are separate from each other. And the way that you interoperated was that you copied pieces of the chart that you thought were important and you faxed them to the other person that you're going to refer to. And that was kind of how the world had been. In the 80s, we started seeing electronic billing companies come into being. And more in the 90s and early 2000s, EHRs kind of grew out of that. So they were sort of a coding maximization tool more than they were a clinical tool. They evolved from there. And now we're at the point where we rely a lot on the electronic data that we have. And there's a lot of data that we have. Now the question of how do we put it all together? My belief is that institutions have data about themselves that's very proprietary to themselves. They don't need to share that. But clinical data is not about institutions, it's about patients. And patient data needs to be across the board. And my belief is that that's kind of where a lot of innovation is happening. Is that how do you get that data not just interconnected but aggregated? And I think what we've seen with health information exchanges as they were envisioned by the ONC, that's really sputtered. It hasn't really. There's a few places here and there around the country where that's been, has been good. But in general, what I've seen is health information exchanges have grown up in places where there's a business need to share data. So they're usually around a hospital or a hospital system, and the community physicians that feed into that. So NYU has an HIE for themselves, but New York City doesn't. There might be a competing one, or that sort of thing. So there needs to be, I think when there's a business need to share the data will be shared. And we'll figure out the technology of how to do that. When there's not a business need, there isn't. And the kind of information that we need to share is the clinical data about our patients, because that's not about institutions, again, that's about patients. Sort of my perspective on that. Which segues into the next question. Which is, as we start to see the aggregation of data, we're starting to see data coming from different sources. HIPAA covers PHI, so that's data that is created by doctors about patients. And doctors can't share that with anybody else without the patient's permission. That's sort of HIPAA in a nutshell, if you will. So we have the new aggregation of PHI from the traditional sources of doctors and hospitals. We also have now a lot of consumer and device-generated data that currently is in the silos in the consumer space. Fitbit has its little silo, and I have a pedometer on my cell phone. That's in its little silo. But those are going to come together. And so then you'll have an aggregated data that's got some PHI that's covered by HIPAA, and it's got some consumer-based data that is not covered by HIPAA. And that becomes both a technology and a regulatory challenge that we're going to have to face. So with all of that, what challenges are there going to be with respect to privacy and security? We haven't really done that yet, but it's going to be there probably within the next year, and we're going to have to face that, I believe. So what kind of challenges do you think there's going to be with respect to privacy and security with combined PHI and consumer-based data?
I'm an experimenter in that space. I've got one of these gadgets myself, which I don't think is really all that accurate, but it's kind of fun. And I think I saw now that like the Tempur-Pedic or one of the beds actually has this gadget kind of built into it. I think this is the whole idea of what Dr. Berwick always walked around saying, nothing about me without me is really powerful. So it's got to come from people. And I don't see anybody, and maybe it's out there, creating a really good like PHI product that could do this. So I could say, you know, I have Google Health or whatever, and I would demand, you know, Kaiser member, like, you need to get a way to put this stuff in here so I can have it here on my phone and make these comparisons and like that. So we all have these little pieces of data spread all over the place. I don't see any way for them to come together unless we bring them together if we want them. And I think when you have a preponderance of consumers doing that, then the whole thing changes. So we didn't know we needed ATMs because we hadn't seen an ATM. My mother wouldn't use one for the longest time because she was afraid of it for whatever reason. Technology adoption takes time, and it has to be easy, and people have to see the value in it. And I think this is the thing, it's kind of like the iPhone where Jobs felt that people would know it when they liked it, but they don't know what they want until they see it. And I think this is true too. And so to the extent that we're beginning to see these consumer products that give people information about their health, particularly ones like this that can collect it without any effort at the point of care. I won't go quite as far as Benioff's toothbrush example, which is he has this internet connected, you know, toothbrush, so his dentist knows how often he brushes his teeth. I don't think we need to know that, but I love getting this little report every week that says like how I slept last week and how active I was. And if they could figure out a way, say for the machines in my gym, to automatically add to that little database, you know, that information would just become that much more valuable. And then when I went to Kaiser, they wouldn't have to ask me if they exercise because they would already know if they wanted to. So I think it'll come. It's about growing the consumer.
Yeah, I think it's hard to have any discussion about health technology without at some point someone bringing up, well, what about the wearables? You know, and it is, needless to say, a critical part of every conversation. But I think one of the things that you see, especially for entrepreneurs just getting started, is to really think carefully about what the claims are for the specific technology, because ultimately that's where the government in particular is going to take quite a significant amount of notice. When you start making claims about real improvements to healthcare, and you start making claims from the information that's derived from that data will actually change the types of either healthcare services that are chosen or the clinician that the patient will end up seeing, that sort of thing. It's a kind of thing that's a slightly tangentially related that we've seen with 23andMe, if you follow that story, which as soon as the claims become, if you go beyond what the technology represents, that's when the FDA steps in and have real regulatory hurdles. But you see such a wide variety of equipment and devices in the consumer space. What keeps them safely there and beyond the sort of clutches of the regulatory bodies is largely by limiting the claims that they make about doing things like health.
So just a very general question. So what kinds of insights have you seen coming from healthcare big data? Big data doesn't necessarily mean massive quantities, I don't think. I think it means data coming from different data sources that you can match together.
Well, if I could just give two examples that I don't know. After a couple of days, I'm started getting this idea what this big data business means. It actually means a whole lot of data, I think is what it looks like, because the data are all the same size. But there's two things that come to mind. One is, under the Small Business and Jobs Act of 2012, we got a little bit of money, about 1/10 of what we thought we needed, to create this predictive analytics program, this fraud control program in our Center for Program Integrity. And so we've got that standing up, and previously we just looked at each claim. We just looked at the claim. Does the procedure make sense for the sex or age of the patient, that kind of thing, would pay or don't. Now, well, because of a need to reduce the budget back in 1978, Jimmy Carter created a 14-day floor for CMS claims, and that took 14 days worth of Medicare out of that year's budget, right? So the claims are just sitting there on the floor. Carriers used to process them instantly to get them out of their system to lower their costs and overhead. So what we do now is every claim, as soon as it hits the floor, every single claim, it runs through this predictive analytics engine that looks at all the other patients that that doctor sees. It looks at all the other doctors that that patient sees. And a whole lot of other connections. It looks at other fraud databases and a variety of things. And you know, through this, we found about 115,000 instances that were actually fraudulent, or rather, we brought in $150 million in the first year, and the payback on this thing is 3 to 1. Now, our general payback on program integrity is 8 to 1, whether it's fraud or whether it's medical review. So this is something that's in its infancy, but I think it's a real game changer around healthcare fraud. The other thing that I think is really significant is since the ACA, when we created a small financial penalty for hospitals to reduce readmissions, we've seen them go from about 19.5% to about 17%. And we think that 10 is possibly realistic. The reason that we have the problem with the readmission isn't that the hospital didn't do the job correctly, it's that the coordination of the resources in the community through home health, through the family, the caregivers, and so forth, and that's forced people to create these networks, many of which we funded, to bring information across the spectrum so that the handoffs work better. That's the one fundamental problem with readmission. So I'm very optimistic about both of those two applications, which in large measure are kind of good data.
Maybe I could just refer to a couple of clinical studies I think are really fascinating and really driven me. And the first is, came out in 2010, and it came out in a journal that's fairly small. It's a journal of clinical pharmacology, and it was a set of Kaiser patients. It turns out the numbers weren't great. They mined a whole ton, tens of thousands of patients. They ended up actually with only 200 patients. And what they did, I thought was very interesting. They went to the FDA, and they looked through all the FDA warnings that had come up. That's where a clinician had given one drug and had some sort of adverse reaction and reported that back to the government. And they went back and they mined that data, and they found that, as it turns out, there were a couple, very few, literally a handful of examples where patients had been given both a statin drug, that's the lower cholesterol levels, and had given that at the same time as an antidepressant. And they found out that for reasons that weren't clear, they had sort of a diabetic crisis, got admitted to the hospital. A few of those have been presented. So the Kaiser group, the IT group, said, why don't we take those two drugs based solely on having mined this FDA sort of warning site that's available, publicly available. So they mined tens of thousands of cases. It turns out they found 200 patients in two separate groups, 100 each group, diabetics and non-diabetics, both of whom had been given the same combination. As it turns out, they found a statistically significant increase in awakening blood serum glucose levels, diabetic crises, a few vascular events that happened over the course of 1 year. And it basically demonstrated that these two drugs that were picked up purely by essentially data mining had a drug-drug interaction. And the only way to find that out was by essentially mining the electronic health record. And to me, even though it was a small paper in a small journal, it was really kind of a watershed event in terms of finding how you can go through the data, take out specific groups of patients and find drug-drug interaction that otherwise no clinician would possibly know. We don't see enough patients in order to make that kind of a finding. And the second was a recent study, so from Finland, so to the degree that you can accept data from Finland because they have smarter people and they're better looking and the healthcare system's better and they're taller and all these sorts of things, but nonetheless, beyond those facts, the fact is that they took a look at 60,000 children. They broke them into two groups, 30,000 apiece. And in those groups, what they essentially did was they did a data mining of growth charts. Now, you would think that growth charts would be pretty standard for a physician could just look at it day after day, or the month after month, and the patient or the child comes back and then make a determination when a child falls off the normal growth, expected growth chart. Was that it turns out a computerized assay is far superior. So they were actually able to identify, again, at a statistically significant rate, more patients, more young children who had, for some reason, growth retardation and fallen off the normal growth chart by virtue of mining the electronic medical records. So I think those are two examples from a pure clinician standpoint, whereby really sort of processing the data, we can come up with novel information. It's not just kind of retrospective studies, it's really going back to the EMR and putting out data that applies to our day-to-day healthcare.
And that kind of speaks to what we call observational studies, as opposed to prospective, double-blinded studies that are sort of the gold standard of medicine. That's what I was taught when I was going to school too. But observational studies, I think, have become the more common norm. And some great examples. There are a couple of really big data sources or data that the federal government has been releasing, which I think will be a source of very interesting analytics. I know upcoming there's going to be the release of the CMS payments to ambulatory physicians. About something like 880,000 physicians or events are being released fairly soon. And I think that will impact analytics a lot. Sort of the belief is that it will impact markets, but my belief is that it will impact analytics. Everybody who seems to be an outlier in my clinical life has always claimed that, well, my patients are sicker. So you can do an analysis and see if that in fact is true. But I'd be interested to kind of hear about what the future is for releasing very detailed sort of patient-blinded data from basically our biggest public payer source, which is CMS. And what that's going to look like down the road, what impact that might have on how we practice medicine.
I mean, here in California, Pacific Business Group on Health, representing large employers in the state, did a physician report card profiling project a few years ago. And we tried to work with them and figure out a way to get the Medicare data tied into that. We couldn't do it then because of this court decision, but we can do that now. And so in the data we're releasing, you'll be able to identify 6,000 discrete procedures over, as we said, 880,000 practitioners. And things are going to pop out pretty quickly. When I came out here working in financial management, California gave the Medicaid contract to EDS. And we had recently given the Title 18 Medicare carrier contract to the National Health Insurance Corporation, which EDS owned. And so we developed a product and put the Medicare and the Medicaid data in California together into a single warehouse and started looking for fraud. And we quickly found people doing more things in a day than a human being could possibly do. Found a lot of fraud in that data. It was very useful, and I think that's exactly what you're going to see here. But what I think is really great, Adam talked about this yesterday, is we're freeing up something that's the people's property, the data that the government has, and make it possible for people to independently both innovate around it and learn things about it. And I think that's going to add to that total, but it creates this big data challenge because it's hard to get useful things out of data that wasn't intended for the purpose you're using it for. And that's why folks like you are here, because you can do that.
Just add that performance metrics really matter. They matter to us as clinicians. We want to know that we're better at doing lobectomies or better at doing lung transplants this year than we were last year. And some of the metrics that are actually being held by the government, we both collect that data and we try to provide the government with that data, but we also want to get that data back. Of course, at some level, I think each one of us may think about where our daughter or our son or our grandparents are going to go, but also like to know that the quality of the hospitals is considered high or that they've reached certain metrics. So I think that the patients ultimately deserve to have this sort of data to help govern their choice in healthcare.
We'll shift gears a little bit and take questions from the audience. We have a microphone perhaps for us? Wire, yeah. Stand up, speak loudly.
So, I'm curious about major pharma and device companies, and so CMS and major research hospital, how does it's still very much a case where we make an estimation of the patient population is based on a few experts, working from animals, and then we don't know about the patient population. And then at the end of the trial, we see we don't do that and it seems like how do you see it going on? Is that today at all? Do you see it on could you repeat the question?
I'll try to synopsize the question. So the way I understood what I heard was that in the field of drug marketing and pharmaceutical development and clinical trials, how can you identify prospectively who the right population of people and test animals are going to be for looking at a drug? Because if you pick the right ones, you might get approved. If you pick the wrong populations, you might not get approved. And that could be really problematic to a manufacturer. And data data available may be able to better target who you're going to be doing your trials with. Is that fair?
That's correct. I
I think it's a critical question, and I think if, for no other reason, even if we do come to believe or continue to believe that the randomized prospective trial is the gold standard, that it's critical to be able to refine those patient groups. And typically what is done at present is sort of a retrospective analysis, looking at phase 1 data, phase 2 data, and then going on to getting well-capitalized investors to engage in more mature trials. And to be able to get to that phase, if you just say, look, it's a certain expense to go through those phase 1 and phase 2 trials, and even if you could just cut into that through excellent data mining, so that then we really do establish our phase 3 trials, and then themselves, we've done it at a sort of a, if you will, a cheaper runway to get there, that would be valuable. But I think sort of beyond that is to reconsider this idea of the value of so-called retrospective data. There's one thing to sort of say, well, you've gone through a bunch of charts and here's the data you sort of milked out of it. That's one thing. But it's another to really have an ongoing rolling database where you're continually asking new questions. Those questions are changing. You have collaborative groups. So I think you have more input, you have the potential to get more valuable data out, of course. Because I think it's a critical question.
Yeah, the one other thought that I had is the ability to work with big data and do analytics around that is in itself a disruptive technology. And I think that the regulatory apparatus at HHS or anywhere else, in the name of safety, has a natural effect of retarding progress until it becomes apparent that that progress can't be denied anymore, and then you see an adjustment. So I think the regulatory apparatus that we have today will probably change pretty soon as we're able to learn more quickly about, because we can model data from doing all over the world and learn about folks. So I think it'll evolve. I hear nothing but complaints about the Food and Drug Administration, whether it's device people, mobile technology people, drug people, and I get that. It's just like people who like to drive really fast complain about radar and cameras and police and stuff. That's the world we live in.
I think, just from my own perspective, recruiting patients for clinical trials has traditionally been around the institutions that carry out the clinical trials, which are usually academic institutions. And so there's sort of a geographic selection of those patients because they tend to be in the orbit of those institutions. I think that one of the results of, again, of aggregated data or combined data or a larger kind of patient-oriented cross-institutional data is to be able to identify potential candidates for clinical trials that wouldn't have been found otherwise, kind of out in hinterland, that are very good candidates, that you can run criteria for who is a good candidate for this particular trial and recruit them. They don't necessarily have to go to an academic center. Much of that of the trial information can be done remotely. And I think we're going to see more of that, sort of less geographic concentration of where the clinical trials happen to be. How many communities look like Framingham?
I'm not sure this is working, but we talked a little bit about the institutional silos. So what about the silos within, right? Like CMS is taking a hard look at hospital-acquired conditions, but then when I look at the ICU, the EMR is not talking to the infusion pump, is not talking to the regulator, is not talking to the patient monitor or the bedside monitor. So that's a big problem with device interoperability, right? I'd love to hear your take on it, and whether CMS would look to push device interoperability with, say, the Infuse 3 or later.
Well, probably no. There's a couple people at Stanford that I know that are put a program together to develop some standards in industry so that these devices can do that. And whether stage 3 is going to require medical record systems to talk to devices, I don't know that we'd be there that soon because we really don't have the standards now. I think now we have to be more worried about the devices interfering with each other rather than talking to each other, because that's a significant risk as well. I'm reminded of when microwave ovens came out, and there was this concern about pacemakers, and we had these signs, microwave oven in use. So I think that's something we want to see. The standards really come out of ONC, and we sort of hand out the money. So it's more their call. I think it also just depends on how long we play this out, because we seem to be willing to wait a pretty long time to get people to catch up before we go to phase 3. I think it's sort of like an Internet of People versus Internet of Things problem, and I think in 2 our real focus is getting this consumer engagement, getting people involved, and being able to get summaries and ask questions and see things. I think the devices, first it's going to be necessary to get them to just work together in the clinical setting, but then probably to the record setting.
I think that you make a good point, and we certainly do deal with a definite hodgepodge of different technologies being operating by an ICU environment, and I wouldn't hold a lot of expectation for a great deal of interoperability in the near future. There are certain standards that are being worked out, and I agree and I applaud those efforts, but I think for the near-term future, you're going to see an ongoing hardware interoperability issue within the medical center. But from a human perspective, you asked a question about silos inside of medical centers, and there are significant silos inside of medical centers, which I do think we can actually break down quite readily. And one simple good example is that the government, for example, has recognized that cancer centers that have multidisciplinary conferences, for example, have better outcomes overall. So that means putting together around the table a medical oncologist, a radiation oncologist, a surgeon, anesthesiologist, nurse, and social worker, et cetera. When you bring those people together, you find mortality rates and overall outcomes to improve. So to the degree that we can put technologies in place that will lower the barrier to collaboration within an institution, that can break down those silos that exist. So the hardware silos, I'm not so sure about. The human capital silos, I think we can break those down.
That's a very good point. You know, one of the things that struck me, I was at the HIMSS conferences a month or two ago in Orlando this year, and you know, the floor, it's kind of overwhelming. I mean, there's 1,200 booths out there, but there were a number of companies who were trying to address the hardware interoperability dilemma there, sort of inserting themselves as an intermediary between devices, hardware devices that don't talk to each other. So there's certainly this effort being made to address the question, whether they'll survive in the business world, whether they will actually work, we'll see. I mean, the market will show. But I think there's a recognition by industry that there is a problem. I'm not sure that waiting for companies to make themselves interoperable with other devices, we'll be waiting for a long time. I think there'll be companies that will be the intermediaries or the universal API, if you will, of devices to local EHRs. Any other questions?
Retrospective data that replaces a double-armed randomized trial with a single-arm non-randomized trial. You said something about now this information is going to come from retrospective data, but could you explain that, or maybe I just totally misheard what you were saying?
Absolutely, and maybe I could be a little bit more clear about the way that I placed the notion of progressively using the data and, if you will, distilling it and then generating data that can be used going forward for the healthcare that we provide. And the concept is this, is that when you take care of a patient, what you want these data mining tools to insert themselves in the sort of process of day-to-day management of patients. So, for example, I may go to the computer and enter in the stage of the current lung cancer that I'm managing. It's a stage 2B lung cancer. And then another oncologist enters in the specific chemotherapy regimen that he or she has chosen for that patient. And over time, what comes to develop is a database that can tell you how a specific stage is managed by a specific, say, chemotherapy option, and then the overall, say, outcomes at 4 or 5 years with respect to survival. Now, right now to do that is actually fairly difficult, even in one institution. But you can imagine when you have a confederacy of many hospitals, all under one electronic medical record, the ability to rapidly assess both treatment options and then outcomes, and then to make some reasonably convincing argument about those treatment options and how they've actually influenced outcomes will come from being able to mine the data more effectively. Does that sort of answer your question?
Institutions on their own are coming up with these ideas within their own hospital or medical center with their patients, and across the country a whole another medical center is coming up with the same thing. I mean, these are published. I mean, who keeps track of all this stuff? Nobody, or people who are publishing it, or just within your institution, or?
Well, you know, we would think, I don't want to answer from the CMS colleague, but I would think that the government takes a direct interest in the outcomes. And so largely, you know, the National Institutes of Health, and of course, will fund investigators to spend time to draw this information out. There's several, IDASIM, there's informaticists at UCSF spends a great deal of time trying to connect cancer hospitals from around the country up to a common standard so that when each patient is cared for, that data is essentially collected and then various conclusions can be drawn. So the individual researcher, if you will, can go to this database and answer questions about outcomes related to specific therapeutic choices.
I might have an example that I heard last year at a conference. So at Stanford, at the pediatric hospital, they had a patient, they came in with a very rare disease, and they had 10 specialists in this group that was, you know, part of who was treating her. And basically they came down to a question, well, should we anticoagulate this patient or not? And 5 said absolutely yes, 5 said absolutely no. So they said, okay, what they did was they said, okay, well, we've probably treated maybe 15 or 20 patients like this over a 20-year period. They went back through their data, they looked at each of those patients, similar characteristics to this patient, and were able to come up with an answer based on historical outcomes from actual patients that they had in different treatment choices that they had made for those patients. And so they were able to make a treatment decision based on historical experience and data that they had, you know, over their treatment careers there at some institution. Well, they got it from their data. I mean, they had data, so they had, you know, enough data legacy and lineage that they were able to pull data from a certain amount of time back.
So, you know, I think one thing that's important is the gentleman that raised the issue about, say, developing a pharmaceutical or a biological. You couldn't substitute this kind of retrospective data for that because there is no retrospective data. The retrospective data seems really valuable in terms of developing evidence of what works. So we know, this gets kicked around, I don't know if it's really true, not to insult my physician friends here, it takes a very long time, let's just say, before something that we know works becomes a common practice. And the thing that drives this home to me is I think about my childhood, I think about my parents smoking. They grew up in World War II, encouraging me and my brothers to smoke, and I smoked for a really long time. The Surgeon General's report was 10 years old when I was in high school and started smoking, but people just didn't believe it because it was part of the fabric of my parents' lives and all those other World War II people. So they just couldn't believe that it's different. I think the same thing is true for all kinds of professionals. You do this thing the same way all the time, and it seems to work, but you're basing it on your small set of sample. When you can get this big, broad sample, then you get to things that we've put in our quality measures for hospitals because this is why we know that they work. Because people do these retrospective studies and they do publish them. So in epidemiology, there's all sorts of study designs. It's just that we're tied to that one gold standard for pharmaceuticals because I think because of the safety issue. It's different to decide between existing treatments than a novel one.
I mean, we're coming up on 20 years of using the term every day of evidence-based medicine. But the fact is that sometimes the evidence is actually hard to get a hold of. It's particularly hard to get a hold of for relatively uncommon disease states. But to be able to turn to a system where that evidence becomes much more readily available is the goal.
Anybody else have any questions? Well, let's go ahead and wrap up. We're actually kind of close to our time here. We'll be around if people want to come up and ask questions afterwards. I want to thank